Hi everybody. So my name is Annette Harwood. I'm from the North West Sector element of Greater Manchester Maternity Pioneer, and I always feel like I have to apologise that I'm not a midwife, I'm a commissioner, and our Pioneer is definitely a commissioning-led model. Our Pioneer forms part of Greater Manchester. This is a map of Greater Manchester, and the Pioneer just covers sort of the left-hand top corner. We're part of Manchester Health and Social Care Partnership. Our Pioneer just covers 3 CCGs, 5 maternity providers, and I've put some public health data there because I am a public health sorry, Commissioner with a public health background, so that will feed through some of this. Our LMS covers Greater Manchester and also another little bit of Eastern Cheshire on the side. So we're not co-terminus with our LMS, but we do feed our learning into that. So quite a different landscape than some of the others that we've heard. Again, I'm going to whiz through some of these. If you get the opportunity to read this as I go along, because I won't mention everything. So we are a commissioning-led Pioneer, and we're true to form in that our aim was to deepen and widen the choice of provider and birthplace, and to develop and implement the PMCBs that we've already heard James talk about. Our ethos was around commissioning a whole systems change, to change the culture in our Pioneer, because we have a legacy of making it better, which a lot of people in the patch thought made it worse, because of how our provider landscape was split at the time. So we thought that being a Pioneer was a really good opportunity for us to try and put some of that right and make a bit of a difference. So as a commissioner, as the 3 CCGs, what we have done every year since becoming a Pioneer is actually written our Pioneer plans into our commissioning intentions, so that our 5 providers know exactly what we want them to do. And it's around working with commissioners to implement the PMCBs, doing this, this and this, and also work with commissioners to implement that widening of choice. Because what we wanted to do was to offer those 4 birthplace settings as directed by NICE, and in the patch we can do that, except for Wigan, which will be offering 3 because they didn't automatically have a midwifery-led unit. So we were using the Pioneer as a real vehicle to change the system. So, quick whiz through what we've achieved through the life of the Pioneer is that all women now across the Pioneer have a choice of the 5 providers. Before, in Salford, where we had 4 providers, it was postcode zoned. So wherever you lived, you got channelled through a certain provider through that midwifery-led team. We wanted to sort of abolish that. We wanted to market test to try and bring new providers into the patch. We'd already had a plan to develop a new birth centre, and we decided that we would go out for tender on that under quite innovative service specification, which I'll talk to you about in a minute, because that birth centre was originally commissioned for women of Salford, and it was based at one of the hospitals. It wasn't really an FMU, freestanding midwife-led unit. We wanted to do it differently. We wanted to use the Pioneer as a badge to innovate. So what we decided to do in specifying Ingleside Birth and Community Centre, our new birth centre, is we wrote a specification around changing the culture and appended it to the service spec. And we wanted it to maximise public health outcomes because of our demographic. We wanted accessible care. This was 2016, so it's a little bit dated now, but still stands. We wanted to look at continuity of carer, personalised care, innovation, and effective use of our resources. So we wrote that down in specification and went out for procurement on it. We also went out for procurement in our extra information for procurement around collaborative approaches, because we wanted to welcome bids from other providers, third sector providers, independent providers, etc., just to start to shake up the system. We also said in that procurement advice that we would seek collaborations with independent and NHS trusts. So we were really pushing the boundaries around trying to innovate that market testing to widen that choice of provider, and also to change the way in which we already worked in that almost clinical, medicalised. For me as a commissioner coming into that, it was like a very medicalised model, so we wanted to bring some of that public health focus into it and that midwifery-led focus. So we managed to get a lead provider, which was Bolton NHS Trust. We did have a bid from an independent, this will be interesting, we learnt from this, we did have a bid from an independent sector organisation, but because of the NHS procurement legislation, it weren't financially viable because they had to have X number of years of audited accounts, and they had to have worked within a contract of a similar size financially. So real lesson learned there around going out for procurement. So they were automatically sort of pushed out of that procurement process because they weren't financially viable for the size of the contract. So we got a lead provider, and then we decided that we would look for a new birth centre. And we found Ingleside, which is owned by the City Council. Another thing that we need to be mindful of is that our pioneer was working within a very political environment and a very political geography, because we have a paid mayor who has quite a lot of influence, and they really wanted to see this work, and they wanted babies to be born in Salford. You might have heard all that before. So it was quite a political agenda, and they were driving some of this as well as the CCGs. So this building is owned by the council, and they funded the refurbishment of it. I'll just go to this slide because that's what it used to look like through the ages. It was the family seat of Pilkington Glass. Those are all the workers on a day out. So we also wanted to make sure that our widening choice again, pioneer head on, widening choice again. We wanted to make sure that our 5 providers were able to use Ingleside. We had a lead provider who has the lease on the building, etc., etc. But we wanted to develop an in-reach model of care, and this was also specified when we went out for procurement. So every one of our providers know that we wanted them to use Ingleside, and that also attracts our continuity of carer model, because the plan is that we have a lead provider and that our other providers, the midwifery teams, have their women antenatally, they go into labour, the midwives from that team come in, use the facility, go out, and off they go. Sounds really simple, but it isn't, because you've got to go through all the governance processes, the finance processes, what do they pay to use the facility, whose governance processes are used, what happens to transfer of care, etc., etc., etc. And we are currently working through that and coming through the end of the tunnel. Hallelujah, it's taken about 18 months, but we're getting there. We've also developed Ingleside into a community hub, better births, community hub, maternity hubs, and we have targeted services operating out of their public health model, feedback to our specification. So we've got the early years teams there, we've got early years teams from children's centres now coming in there, targeting our vulnerable families. We've got routine antenatal clinics there. We've commissioned the Citizens Advice to do a bespoke package to pregnant women around advice, around housing, debt advice, tax advice, and it is oversubscribed by 200% in the first year. Got to do something about that. And we've got hypnobirthing and aromatherapy. So this widening of that choice offer, this one-stop shop for where those women could come, is what we're trying to provide here. Oh, this is just goes through these. Oh, no event is. She's here. She came to our opening, which was really good. Let me talk about PMCBs, because Again, it's a commission model. We wanted our PHCPs to work with our one-stop shop, with our widening of provider. So what we decided to do is to go for a big bang and charge all our providers with offering the choice of each other at that first point of contact, at that booking appointment, which I think we were one of the first pioneers to do. We just did it. And that has been fraught because as providers yourselves in the room, you'll be wanting to keep that tariff, you'll be wanting women to come to you, you'll be wanting to showcase your own services. But we developed our choices booklet that you've seen before, that other pioneers have developed, and we wanted our midwives to give that choice offer of all 5 providers, and that's what we started doing right at the outset 18 months ago. We continually assess and review the information in that choices booklet because we're continually evaluating our services. We did the midwifery training. You've heard about that before, so I won't go into that, but just let me talk to you a bit about the evaluation. One of the members of my project team around the pioneers, the University of Salford, one of our partners, have been a really key partner to have because they do our training independently, they're seen as being independent, but also they do our evaluation, and we do a snapshot of time evaluation every 12 months. We did one last year and we started this year. It's linking into the national evaluation. We've had focus groups, we have social media, we have a Facebook page which is our virtual MVP, and we have 2 what I call real MVPs with real people on them. So we use those groups for our evaluation. But this time, because we've done a lot of training with all our midwives around, this is the conversation, this is what you've got to have, this is better births, this is what we want you to say, we want you to have the money conversations, blah, blah, blah. Go forth and enjoy work and do it. So then what we did, we asked the 3rd year students who were placed with them, what conversations were they having with the women? Were they offering true choice? Were they offering the choice of each provider? Were they offering Wigan? Were they offering Manchester? Were they offering Pennine, etc., etc.? Well, the answer is no, they're not. And this is another lesson to learn. Midwives with the best of intentions, and I don't think they've realised they were doing it themselves, say in the middle of Wigan, which is quite a long way from Ingleside Birth Centre, weren't really offering Ingleside Birth Centre because they subliminally thought that it was too far for women to travel. So there's some real, and that was happening across the patch, in other areas across the patch where, or perhaps I won't, no, she lives too far away, so I won't really offer that choice offer. So we have quite a bit more work to do, and we're starting next week in a learning day to make sure that we've got that unbiased choice, because what we haven't got in our Pioneer is a single point of access. And all our roads, in all our evaluation, and the finances, and the governance, is leading, and the choice offer, and the continuity, is leading to that we need to set up a single point of access. And that probably then needs to be shared and widened across the LMS. And therein lies a whole another service development that will require funding, etc., etc. So when the evaluation is finished and comes through in January, we may have some powerful information there to go back to the 3 CCGs, our LMS, NHS England, to say we need to start this single point of access. We need to work in a different way because we started the ball rolling. So our next steps is to finalise the enriched model of care and share that, because I know NHS England is really keen to see how we've done that. We need to scope the single point of access and continue our PMCB evaluation, and we also need to start scaling and spread, is the word that we use, around widening what we've learned, and today is one of the reasons why we're doing that. I can't tell you how important it is as commissioners that we've put this in our commissioning intentions with our providers, that we set that up right from the outset, that this is how it's going to be, this is how it's going to look, and no matter How much some providers might say, no, we're not part of this. Well, sorry you are, because it's in your opening contract. That's been quite interesting. So, title of my presentation, A Labour of Love. Well, yes, it is, because I've got this project group. We meet at Starbucks because it's central to our patch, and it really gets the mind thinking that you're only there for 45 minutes on a cup of coffee and then you go, and we meet every 2 weeks. And on that Starbucks group, we've got my trust champions, which have been absolutely amazing. These aren't particularly heads of midwifery. These are deputy heads or consultant midwives or community leaders or even community matrons. We've got 5 of them, and these women, these midwives, have been the ones that have infiltrated their trust and absolutely forged ahead with the plan, and I cannot thank them or celebrate them enough, really, because they've been absolutely brilliant. We've got the 3 CCGs on there, and we've also got the University of Salford, and that's 6 of us or 8 of us. We all get together every 2 weeks. Where are we up to? What do we do next? Off we go, and we do it, and then we catch base again 2 weeks. But it's also been a really good group because we've had tribal boundaries. This is another public health term. We've had health tribal boundaries where none of those trusts spoke to each other before. And now I sit back and I watch and I listen to them and they go, what are you doing about continuity? How have you done that? What about your continuity? What about, and they're all sharing, and also they're coming with the problems, you know, some of the problems that they're experiencing within their trust. It's been an absolutely brilliant group. We're sharing skills and knowledge amongst that group, but also that just goes wider because it has a ripple effect. And then we're forging friendships and trust. They didn't trust each other when we first met in that room. It was all the case, they were all very quiet. But now, absolutely, the trust is there. They have a fundamental belief in the pioneer and better births, and that really helps. And also with the pioneer, we've got leadership. We've got leadership with me being there as a programme lead, but also leadership within the university now and within those 5 champions. And within the CCGs, because it's put it on the map for CCGs. Sometimes in CCGs, maternity isn't at the forefront of everybody's mind like it is with us. But being a pioneer has really updated that, and it is now more of a priority than it was before. So yes, the pioneer has been a labour of love.
Thank you.